East of Guwahati.
East, yeah. Okay. It's further ahead.
Yeah, further to the east.
On the airport.
Yeah, now there are a lot of airports coming up this side also, which is good. Just yesterday I saw one airport which I didn't even know the name of the place. Then I looked it up. It's in Assam only. I didn't even know that one. It's in the western side of Guwahati. So lots of small airports are opening up, which is good. And I think, yeah. And we have another 3 minutes.
3 minutes.
Charles, you got the link or not? Everyone?
Dr. Charu, are you there?
Yeah, I think she.
Good evening, doctors.
Hi.
Hi, Dr. Soham. Thank you very much for coming, Dr. Ravi, Dr. Rukmini, madam. Thank you, Dr. Pankaj, Dr. Charulata, Dr. Rupam sir. Thank you all for.
So, Michael, you are
coming to the product.
Supporting this.
Pardon me, sir.
How are you doing?
I'm fine, sir. Just returned home from office. Traffic jams are lots. Hello, sir. Dr. Sanjay. Thank you very much for being present.
Good evening.
And thank you very much, sir, Dr. Chaturbuj.
Hi, Dr. Sanjay.
Hello.
Yeah, it's a pleasure to be with the galaxy of movement disorder experts. I have never been in the movement disorder session, so that's look great.
So we have what, 2 minutes?
Yes, 2 minutes.
Rukmini.
Hi.
You want to check your slides, Dr. Rukmini? Just if,
Okay,
or it's okay.
I think I can just check once.
Yeah, just
Are
check.
you able to?
Yeah, she's able.
Yeah.
Good.
Okay.
I think I can start with this and end with this. So, correct.
I'll also have to show something after that.
Yes. Correct.
Yeah.
I just posted in a movement disorders group WhatsApp. The ones who are free can join and grill you with questions. Both
Yeah,
of
thanks. Thanks for that.
you. So I'll just begin it and then read the comments at the end. I think there is echo from somebody.
Michael sir, आपका mute कर दीजिए for the time being.
Sorry.
My
Done, sir.
You're good to go when you say we can start. If you open it up for all.
So how are you planning to do the poll thing?
Yeah, वो कर लेंगे. Can you stop the practice session support team and begin the webinar mode?
Yes, sir. It is sharp 8 o'clock, sir. Shall I initiate? Allow participants to join? Allow attendees to join?
Yes, and stop this practice session.
Sure. I'll just start. Yes, sir. The attendees have started to join.
We'll wait for a while and then start.
Sure, sir. Sure.
Let a bit pour in.
Maybe they can just write in the chat box. So
No, I'm just saying like 30, 40 people are there, we can start. So 40 already we have.
No, I'm saying the voting.
Huh.
How are they going to vote? They can write in the chat box? Or
No,
what?
no, they'll run a poll.
Oh, there's a way to do that.
Huh, there's a way to do it. Maybe I wait for 30 seconds and start. So we are nearly 50. I'll start. Welcome all. Good evening to this session of controversies to consensus in neurology, where we are going to discuss different topics of different neurology specialties and have experts' opinion, talk on things where we may not have a consensus or there may be a controversy. So, as we all know, Parkinson's disease is one condition where for years patients were not having treatment, and for years people believed and had a nihilistic attitude that Parkinson's disease is a degenerative condition with no treatment. That changed over when we had levodopa, carbidopa come in, and patients for the next 30, 40 years, they felt that they had a honeymoon period of the therapy, where for the first 3 to 5 years, they had very good response and they could do normal work. But subsequently, again, we found out that levodopa, carbidopa itself had its problems, and sooner or later, patient would develop other complications, motor complications, fluctuation, and all. And then again, there was a bit of a time for a few years when we thought that there is not much to do. Then, by serendipity, Benabid found out that if we stimulate the brain specific areas, there is a significant improvement, and that started the era of DBS. And subsequently, with 2 trials in the veterans NIH trial and the Intrepid trial, DBS was like established in the treatment of DBS in advanced stages when they have problems. Subsequently, now there have been a thought that why should we keep waiting for a long time for the patient to have poor quality of life and then go for this second therapeutic honeymoon? Why don't we have it early so that the patient's quality of life and other things can be preserved early on? So to discuss this controversy, we have 2 eminent speakers, Dr. Rukmini from Hyderabad and Dr. Pankaj Agrawal from Mumbai. So they will debate against whether to do DBS early or whether we at least wait for a while. And there are issues with early DBS, and they'll be fighting against each other on this topic. And to decide the final opinion and try to get a consensus from this controversy, we have 3 people. Dr. Rupam Borgoin, again from Hyderabad, one of the person with the highest experience of DBS in our country. Then we have Dr. Charulata Sankla from Hinduja, Mumbai. And we have Dr. Ravi Yadav, professor at NIMHANS, Bangalore. So I welcome all of you. I hope from the fighting part, we can reach some consensus in this 1 to 1.5 hour session. I am Dr. Soham Desai. I'll be moderating the session. We also have Dr. Chaturbhuj, Dr. Sanjay in our team, who are like other moderators for the other neurology subsections. I welcome all the audience. I'll also request the audience that they can write things in the chat section. Once we have the opinions of the experts, we'll have answered their queries too. So first of all, we'll have a poll to see what is the current belief of the participants. If we can have the support team give the poll, the chairpersons and the panelists can't vote, so that we don't want them to get biased in getting the answers. So if we can have the
shall
poll.
I insert the poll now?
Yes. So till they bring in, there are 3 options. First is the yes, DBS should be done earlier is better. The current criteria to choose DBS are too restricted and often late. That is the first option. Second is not early. We need to wait for the patient to satisfy current mandatory criteria of DBS. Earlier may not always be better. The third option is I am not sure. I need more information. So let's see what percentages do we get here.
By the way, Soham, I have already voted.
Yeah. I wanted that we don't vote, but I think still.
It was showing an option. So
Pankaj, I'm sure you voted for earlier.
I just want to clarify, Soham, early means early into disease, late means late into the disease, right?
Early means like what we say the current criteria is we at least wait for 4-5 years, start motor
5
complications
years.
develop.
Yeah.
Yes. Early like a
And
bit
development
early.
of on and off fluctuation,
Yeah.
dyskinesias, and levodopa lability of the levodopa response. So that is what you mean by current this thing.
Yes.
And when you say late, what do you mean by late? That means are you going to stick to the debate is going to stick to the current state versus early?
Late is the current state.
Late is the current state. Okay, fine. Okay. So Pankaj is going to talk about the current criteria and Rukmini is going to fight out about whether should we be following current criteria or should we be going for early DBS, correct?
Right. So can we see the results of the poll?
Sure, sir.
Okay, so we have more than half of the audience with Pankaj even before people have started, but 1/3 do feel that earlier should be better. So there is some support for Dr. Rukmini too, and there are 10% who are not sure. I think those are the one Dr. Rukmini and Dr. Pankaj have to convince to go onto one side. So whether we will make them give one opinion or we will confuse them after these talks, that we will know after the second poll and then the third poll. So once the two speakers give their opinions, we'll have a call again. Then we'll again open the session for Dr. Rupam, Dr. Charu and Dr. Ravi. And once we have listened to everybody, we'll again have a final one. Thank you. I'll end here. I'll keep a watch on the chats and questions.
Sir, shall I stop the result now?
Yes, you can stop the result and allow Dr. Rukmini to begin her talk. Thank you.
So thank you, Dr. Soham and Dr. Chaturvedi and Dr. Pankaj, Dr. Sanjay for letting me be a part of this. It's interesting. I mean, the current criteria is a little controversial itself by itself. But let me start with, for me, the DBS for PD early means early motor fluctuations. So I will be discussing in these points that Parkinson's disease is progressive. DBS is definitely an effective therapy for Parkinson's disease. The effect of DBS is long lasting. There is no waning off in that sense. Benefits of DBS in the early motor fluctuations are good. And the question is, does DBS modify the course of the disease? So we know that Parkinson's disease is a progressive neurodegenerative disease with widespread pathology involving various neurotransmitters producing cells. And we know that it progresses. I mean, there is no patient with Parkinson's disease who doesn't progress. I mean, that is, I think, the underlying caveat. And as the disease progresses, the disease modifies. Initially, you have bradykinesia, rigidity, and tremor. That 0 to 4 years is where the patients respond very well to medication. From 4 to 7 years is the mid zone, or where they start to have some motor fluctuations, and then they start to have higher fluctuations in dyskinesias, and it becomes a very complicated disease because the fluctuations and the dyskinesias and motor complications as well as non-motor symptoms come up into the picture, and then more than 10 years it becomes the patient develops psychosis, dysphagia, postural instability, freezing of gait, falls, etc. So what are the limitations of medical therapy? We all are so enamored by the fact that dopamine was available and it was like a miracle drug. I mean, it's still a miracle drug and you have a honeymoon period. But over a period, beneficial effects of the dopaminergic medication are hampered by the appearance of motor complications. So you can have fluctuations or sudden knocks, or you can have severe dyskinesias. Like in this patient where you can see that the patient has got very severe dyskinesias which is happening. The other problems that happen with dopaminergic drugs are patients develop impulse control disorders. They can have psychosis, nausea, and weight loss. Some patients don't tolerate medications at all. And so these are the things which happen as the disease progresses. So if you want to see in the initial period, when you have blood levels of levodopa in the mild stage, the patient actually has a good on and off. So they're good throughout the day. But as it becomes moderate, they start having wearing off, and sometimes they can be predictable or unpredictable wearing off. And then you develop dyskinesis, which is a light blue, which is on top. So this therapeutic window kind of decreases as the disease progresses. And this is definitely true with all patients who are on dopaminergic drugs, especially with young onset PD, where we get dyskinesias almost in 100% of patients who have levodopa for more than 10 years, approximately. So now that is the point. So Parkinson's disease is definitely progressive. Right now, we don't have any medication to stop the progression. We don't have any medication for a cure. Now, when you look at DBS as therapy for Parkinson's disease, we know it has been a very effective therapy for Parkinson's disease. The initial RCTs, which were 2 of them, and then later 2 of them involving some 136, 156, 255, and 350 patients with severe motor complications, confirmed the finding. At this point, DBS was tried out in advanced Parkinson's disease, and even in them, it improved the on time without troublesome dyskinesia by 4.6 hours per day, which is quite effective. The motor function in 49 to 71% of the patient compared to 36% in medical therapy. And there was a marked improvement in the quality of life 6 months after the session. And there have been a lot of studies after that, and this is a review which came up in 2018. And you see that the UPDRS 1, there was not much of an improvement, but the UPDRS 2, in the on and the off, there was a significant improvement in patients who had undergone DBS. Similarly, with UPDRS 3 on and off, where they had a significant improvement with patients who have undergone DBS, you can see that the off scores improved remarkably much more than the on scores, which is what we expect, because the on effect of levodopa lasts for a long time, even till the last stages of the Parkinson's disease. If you look at dyskinesias or UPDRS 4, the motor complications definitely favored DBS compared to that without them. If you look at the quality of life, almost all the studies have shown that there is a marked improvement in the quality of life, which was in favor of DBS compared to those with best medical therapy. Now, these studies are all based on 6 months to 2 years follow-up, and we look at the LEDD, that is the levodopa equivalent daily dose. It has come down markedly in patients who are undergoing DBS. There is a problem with that DBS was that they were higher experience of serious adverse events in terms of the bleed or infection, and this was definitely more in favor of patients who had DBS compared to those with best medical therapy, because there was surgical complications with the surgery. If you look at non-motor symptoms, we think that the non-motor symptoms don't improve so much with DBS, but actually there is a significant improvement in non-motor symptoms, especially with cardiovascular, sleep domains, urinary domain, weight loss. These are all the things which improve with DBS. Now, is DBS the only drug which is available as a continuous dopaminergic stimulation? No, we have actually the levodopa, carbidopa, interstitial gel, and apomorphine. But if you look at the effectiveness of the 3 modalities, and this is a review which looked at 22 studies, we see that DBS definitely improved the off time markedly compared to that. DBS was comparable to levodopa, carbidopa, interstitial, slightly better, but compared to apomorphine or best medical therapy. If you look at the PDQ-8, PDQ-8 at the time it was done, it was definitely more with it was again similarly, there was significant improvement with levodopa, carbidopa, interstitial, and DBS. So these both are equally effective continuous dopaminergic stimulation. If you look at the non-motor symptoms also, there has been significant improvement in the SC and DBS compared to the IGLI and apomorphine. So DBS plays a major role in improving most of the motor and few of the non-motor symptoms. If you look at the duration of the efficacy, is it only a short period, 2 years? No, it is actually, people have looked at studies which have done 5 years after the surgery. Even after 5 years after the surgery, if you look at this is a 5-year follow-up study which shows that the tremor, the rigidity, bradykinesia, the motor examination compared to the baseline, even after 5 years, it's only half of that. So there is a marked improvement, and that persisted even 5 years after surgery. You expect actually the motor scores to worsen over time, but in this case, it's much better than the baseline itself. The other studies which have seen around 15 years or 8 years after surgery, you can look at the on and the off score. So this is the on-off scores, and you can see that the The purple line is actually more than 8 years. The blue line is in the patients who have not undergone DBS or the baseline. And so this is, you can see that even compared to the baseline, even around more than 8 years, there's a significant improvement in the UPDRS OPS scores. The OPS scores remain fairly same in all the, at all the times, which is comparable to that of the pre-DBS surgery. Again, as we know, the OPS scores are really good in patients with Parkinson's disease when they are taken levodopa. If you look at the 15 years follow-up, you can see that there is a significant improvement in the time spent in the off state as well as the time spent in dyskinesias. This is persistent from 1 year to over 15 years. And again, this is in the same study, we looked at the PDQ, the quality of life that is also significantly improved, remained better than the baseline even after 15 years. The Parkinsonian symptoms tend to come back to the baseline at around 15 years. The other systemic symptoms domain actually stay improved. Now this is just an example of a patient, the same patient that we saw the dyskinesias. You can see that the patient is in the off state. This is advanced PD. The patient has got severe dyskinesias. And this is a patient in the on state without dyskinesias. And if you look at the same patient around 9 to 10 years after the surgery, this is where he was. And this is around 14 to 15 years after the surgery. The patient is able to walk well. His condition is still better than the off stage during the days before the surgery as well as the dyskinetic phase. So this is something. So this is suggesting that there is a good improvement. Now, when we know that DBS works in the advanced Parkinson's disease, and we know that Parkinson's disease is progressive, what happens in patients who have early motor fluctuations? Now, the early motor fluctuations are fluctuations with less than 3 years after the start of the motor fluctuation, and this was actually looked in by the early STIM study. So if you look at the patients who had early STIM, 251 patients with Parkinson's disease and early motor complication, age were less than 60 were taken in, and they had a mean duration of disease of around 7.5 years. This was done in 2013. Before that, the duration of illness before the patient could be taken up for surgery was around 10 to 14 years. And I think that is kind of standard therapy even now. Even now, the European guidelines suggest that you try apomorphine, try levodopa, carbidopa, anticyanogen, and then go for DBS if the patient don't improve with these two therapies. But if you look at the study there, and you look at the motor outcomes, all the motor outcomes improved remarkably at the end of 2 years. The UPDRS3, the Horn-Anya stage, the presence of good mobility, dyskinesias, levodopa equivalent daily dosage, the presence of dyskinesia, motor fluctuation, all of them were significantly better in patients who had undergone DBS in the early STIM study compared to the others who had only the best medical therapy. Look at the quality of life, which was mentioned. Again, there was a marked improvement in the quality of life in almost all the groups in which patients had all the aspects of the quality of life scores. If you look at the entire summary of the scores, there was an improvement in quality of life, improvement in motor score, improvement in activities of daily living. There was an improvement in UPDRS score. There was improvement in scales for Parkinson's psychosocial questionnaire where the patients felt better. There was a definite drop in the amount of levodopa dosage. The adverse effects, when they were looked at both the neurostimulation and medical therapy, were similar. There was the numbers were similar. The death by suicide was more than, 2 in the neurostimulation and 1 in the medical therapy. Definitely, there was an event related, to surgery or device was around 17% in the patients who had neurostimulation compared to the medical therapy. But the rest of the stimulation, like even related to medication or stimulation, was much less compared to that with the medical therapy. So overall, at the end of 2 years, the number of stimulation was, number of side effects was similar. So if you look at just the outline of what happened in early STIM, there was an improvement in the quality of life. There was improvement in UPDRS by around 53% in the neurostimulation compared to 4% in the best medical therapy. And medication dose was reduced by 39% in the neurostimulation group, but increased by 21% in the BMT. When you look at the cost utility ratio, the cost of the surgery and the follow-up is definitely much less compared to the improvement in the occupational capacity and the reduction of burden on the carers. And so SCN DBS at an early stage is definitely cost effective in patients below the age of 61 because this is based on the patients who had undergone the DBS in the early STIM, and so this was cutoff was taken as 60 years at that point. Wasn't that the only trial which looked at early Parkinson's disease? I mean, Parkinson's disease with early motor fluctuation. There was a prior study, like a pilot study, which they had looked at in 2007, where the same group had looked at 20 patients, and there they had taken 10 pairs of patients who had undergone medical therapy and those who underwent surgical therapy. Again, the same parameters were included. Patients were less than 55 years, had disease duration of more than 4 years, had side effect profile, I mean, motor fluctuations of less than 3 years, and they were taken up for surgery as early SPN stimulation. And if you look at the motor disability UPDRS-3 score, you can see that there is a significant improvement in during with the SCN stimulation. The black ones are the UPDRS off and the white ones are the UPDRS on. So both of them have markedly reduced compared to the baseline, and this actually improved over up to 18 months after the surgery. Motor complications were definitely better. The levodopa equivalent dosage was better. If you look at the quality of life, there was an improvement. The activities of daily living was improvement. Frontal scores and the NBRS, the mental status, was similar in both the groups at 18 months and at inclusion. The psychiatric assessment also suggested that there was not much difference between the two groups. Now, there is a long-term follow-up of these patients, the 20 patients. This was actually presented as an abstract in Movement Disorder 2016. So, out of the 20 patients who had come, they included in the first pilot study, 4 had died, 2 in each group. All the surviving 16 patients were assessed around 10 years after the randomization. And all patients initially randomized to the best medical therapy had meanwhile undergone SCN DBS with varying delays according to their individual choice. So is there a point in waiting for so long or waiting for so much when at the end of the 10 years, all of them had undergone DBS? Follow-up assessments were performed, and at last follow-up, there was no difference between the groups for all outcomes. So definitely DBS is better, DBS is more effective. Early DBS seems to be fairly effective. It has shown that there's a benefit. Is there a DBS which is neuroprotective, or does it modify the whole process of the disease? Well, we don't still have any human studies which suggest that DBS is neuroprotective, but rat and monkey models have shown a beneficial effect. So patients have been put on very early DBS, that is very early PD, before the onset of motor fluctuation. So these were the study was done again, which is a very early PD, 30 patients with idiopathic Parkinson's disease on medications more than 6 months but less than 4 years, and without motor fluctuation and dyskinesias were randomized. So mean UPDRS total, and they were looked at for 24 months. The mean UPDRS total and pathway scores were similar at 24 months. These are very, very early Parkinson's disease patients, very, very happy with their medication. But the scores at the end of 24 months were similar. The DBS group took less medication at all time points, and this reached the maximum difference at 18 months. 2 patients had serious adverse event. One had a bleed and one had an infection. So what was done was a posterior post-hoc analysis was performed about the same group in 2015. So DBS plus optimal drug therapy subjects experienced a 50 to 80% reduction in their motor scores, as well as the total UPDRS complication of therapy and PDQ 13-9 significantly worsened in the best medical therapy. So this seemed that the DBS group was better. A 5-year follow-up was done for these 30 patients, and when they were looked at these 5-year follow-up, the UPDRS-3 on scores remained similar. They didn't do a UPDRS off score, but the ones who had tremors had much better improvement with DBS compared to those who had not undergone DBS. If you look at the levodopa equivalent daily doses, the amount of medication came down drastically in patients with early DBS with optimal drug therapy compared to those who were only on drug therapy. The proportion of subjects on polypharmacy also are much lesser in patients with early DBS. If you look at dyskinesia severity and the presence of dyskinesias were lesser in the patients with DBS, but this is a small group and it did not reach statistical significance. It was around 21% of the people who had early SCN DBS who had dyskinesias at 5 years, compared to almost 50% of them, those who were on best medical therapy who had dyskinesia. But they had a 10-year follow-up. Unfortunately, they could not have more than 10 patients at this particular point. So these patients, the ones who had included in this 30-year follow-up, had included ages from all ages, even including up to 75 years of age. but there was about 10 patients in this whole group had died, and there were 4 or 5 patients who were lost to follow-up. So the 10-year follow-up was only for 10 patients, and out of the 10 patients, what happened, what was seen was those 3 were who had undergone early DBS, that was just before even the onset of the motor complication. And then out of the remaining patients, there were 3 who had undergone DBS in the subsequent years, and 3 of them had not undergone DBS. So when they looked at the PDQ-39, they found that there was a significant improvement in only 3 patients, and these 3 patients were the ones who had undergone DBS. One of them had undergone early DBS, whereas the others had undergone subsequent DBS, initially taking medical therapy. This paper was actually based on a patient experience, so they had a lot of discussion. It was a patient, there was a lot of comments from the patient, so they included everything, just not the PDQ-39. It was a subjective assessment of what the patient felt as a hope, and as well as what they received at the end of the 10 years. So the patient who actually had undergone DBS at the age of 75 years, and these patients, so to exactly find out what is the impact of the DBS, these patients actually had a washout period, because they were taken up very early in the disease course, obviously, so they had no idea about how severe the disease was. So all of them had washout courses during the initial 2 years, and also at the end of the 10 years, they had a washout period of around 1 week of stopping the stimulation and to stop the medication for around, 3 or 4 days, to whatever they could tolerate. So this patient, who was 75-year-old and was 85 at the time of the interview, I told them that they had only had tremor in the initial period and was persistently perfectly normal the whole time. So he was not, for him, he never underwent the concept of Parkinson's disease and had a very normal life for the next 11 years. He did not want to stop the DBS, so he didn't like the concept of the washout period itself. So this is something which is very interesting, to suggest that the patient who had a very early DBS lived a very normal life for 11 years and then was very happy with the DBS, that he doesn't want to even switch off the DBS. He doesn't want to know what DBS means, or he doesn't want to know whether he has rigidity or bradykinesia when the DBS is switched off. Similarly, the patients who actually had the highest increase in the PDQ-39 after undergoing early DBS was the most happiest with the early DBS, because he thought that he would, because of the washout period, he realized that he was much worse without the DBS than with the DBS, and he was very happy that he had undergone the DBS 10 years back. He was 56 when he underwent DBS, and he was actually followed up till around 69 years. This is only 11-year period, and so he had quite a good occupational life after undergoing the DBS early. Now, apart from this, there has been no suggestion that it actually modulates it doesn't, in the study, they did not find the difference in the UPDRS off and on scores or the other motor score when the DBS washout period was used. So that means that they didn't seem to have any specific benefit of the DBS in preventing the disease progression, but definitely they had a better quality of life during that process. So if you look at patients who have undergone DBS versus those who have not undergone DBS, there's definitely we don't have proof to say that it is neuroprotective, but what is definitely shown that it reduces the amount of falls. This is a study where they looked at patients who had undergone DBS for more than 8 years, and they compared with controls who had not undergone DBS. So they had a reduction in falls, they had a reduction in psychosis, there were lesser number of patients who were placed in the nursing homes, and definitely there was a survival benefit compared to those who did not undergo DBS. So definitely DBS does improve the quality of life and probably makes them much more fitter in terms of their mental and physical state. Now the problem with DBS is the worry about the side effects of the DBS process. So the DBS procedure has evolved. It has become more safer. It has become more precise. The imaging is much better. The surgical planning is much better. There's an avoidance of even the tiniest blood vessels. There's improved hardware and software. So there is definitely an increasing expertise and experience. So now I think that DBS has now been, it's been long considered as a rescue method, and it has to shift over from a rescue method to a treatment tool. Because if we look at patients who respond best to DBS, are the ones who actually have short-term DBS. But younger age, tremor dominant, good response to levodopa, no axial or cognitive symptoms, no psychiatric symptoms. These are the patients who respond very well. The ones who don't have very severe dyskinesias, all of them are actually a good option. I mean, even those with severe dyskinesias improve. But the thing is that it has to be considered as a treatment methodology. It is not that it is to be used as a rescue when the medication doesn't work. So if you ask me, early is definitely better because it can optimize the functioning and improve quality of life from earlier. It reduces the complications related to medication. It's more cost effective. Patients earlier in the disease are younger and hence may tolerate surgery better with fewer side effects. They have a better physical and mental status before surgery and are able to maintain the same afterwards. The possibility of a neuroprotective role is plus minus. And this is a patient who has severe tremor with motor fluctuations where she has to be held on to with both her father and her husband to prevent the amount of pain and discomfort that she has it. So when you look at this patient, I mean, does she need to suffer all this is a question. So this is post DBS, but the time that she has spent in that period is definitely not worth it. So these are two patients who are, on the other hand, who are doing extremely well. This is a patient who has undergone DBS and is cycling around 15 years back. This is a patient who is actually walking around, and he's a man who's got, I mean, he's able to jump, and I mean, he's able to actually hop on one leg. I think he's more fitter than I am. So do you think that we need to wait for them to develop a motor fluctuation or dyskinesias which will make them lesser than, and then only go for surgery? So early is definitely better. And I think that is the way to go forward.
Thank you, Dr. Rukmini. So I think she has gone hammer and tongs to support that in PD, DBS should be considered early. Earlier is better, but we'll have to listen to the other view. So Dr. Pankaj, I welcome you to start sharing your slides and say why you feel that earlier may not always be better.
I just have one question for Rukmini. You showed that study, and was there any comparison of onset of the dyskinesias in the two groups? Because the people who underwent very early DBS before the fluctuations began, and the people who went late, the dyskinesias when they reached 10 years follow-up or 5 years follow-up, were they similar or were they different?
They were definitely different.
Sorry.
They were different. The number of patients who underwent dyskinesias were definitely less. I mean, who actually had dyskinesias were less in the patients who had undergone DBS.
But they were not statistically significant. You only showed it in your slide.
Correct, ma'am. Correct, ma'am. Even though 10-year follow-up is a very small group, 10 people.
Dyskinesias is not one of the plus points of going for the early DBS. That's what they had shown early, starting levodopa and starting levodopa late in Parkinson's disease had no effect on when the dyskinesias were beginning in the Italian study that they showed. So I think it's similar.
No, Charu, sorry to interrupt you. That's why I wanted you to know the format. The format was that both of them present each other. They do the poll before and after, and then only we get into that. I mean, experts get into that.
I agree with Dr. Rupam's stance, ma'am. The format is that we want you, Dr. Rupam, Dr. Ravi, to take us from controversy to consensus, but let us stir up the controversy further, ma'am. We'll have this.
Talk about.
We will take that. I think let us see how Dr. Pankaj defends his view. Thank you.
Okay, should I start?
Yes.
Okay, so thank you very much, Soham and the organizers, for asking me to speak. And after that excellent and very stimulating talk by Dr. Rukmini, I will be speaking in favor of late DBS, and by late we will see, what we mean exactly. So I think before this session started, or as soon as it started, Dr. Soham has taken us already very beautifully through how levodopa came, and then how electrical stimulation came in the 90s, and how DBS sort of developed over the last 2 or 3 decades. So that is well known. And today we are not debating whether DBS is safe and effective and improves lives in Parkinson's disease, because there is a tremendous amount of literature in the last 2 decades. So therefore, there is no debate absolutely that DBS is safe and effective and it improves lives. But this debate is about something else. It is about early versus late, and it is to examine whether it is advisable to do DBS after motor fluctuations begin, but either within 3 years of onset of motor fluctuations or after 3+ or several years after the onset of motor fluctuations. So this debate is about that. Early does not mean before motor fluctuations, and it simply means early means after motor fluctuations, but within 3 years, and late means after motor fluctuations and more than 3 years. So that is the sort of ambit of this debate, just to be clear. We are not advocating that DBS should be done very late, and some patients, Dr. Rukmini showed that, they were quite disabled, and so of course, no one is advocating that we should wait that long. It is only whether you want to do it within 3 years of the onset of dyskinesia and offs, or a little after that. So traditionally, when is DBS done? So we all know that once the diagnosis of Parkinson's is made, there is an early treatment, and that produces a honeymoon medical treatment. And for the first 5 years or so, 4-5 years, it can be easily managed medically. And we simultaneously, of course, watch for atypical features in a given patient. Now, as Dr. Rukmini has said, after 5 years and after typically 8 or 9 years, around 50 and 90% patients will develop motor fluctuations. So almost all patients with Parkinson's on medical treatment will develop motor fluctuations within around 9 or 10 years. So for the first 5 or 10 years, actually medical strategies are the way to go. We all know this, we all do this, everyone does this, and with good reason, because there are a number of medical strategies which will help us to optimize treatment, keep our patients living very well. And it is only after 11 years or 13 years or later, and this varies according to the rate of progression in different patients, that these patients become increasingly difficult to manage motor fluctuations wise and otherwise, and then we consider DBS. So this is traditional, this is what we do, and there is a lot of sense in what we traditionally do. We'll examine a few reasons as to why. So of course, later after the early introduction of DBS, there were attempts at pushing the envelope, and Dr. Rukmini told us about the early STIM study in 2013, and that showed an apparent benefit in early Parkinson's disease. And what is early Parkinson's? So PD patients with less than 3 years of motor fluctuations. And in this study, there were 251 patients. And I think all these selection criteria were shown by Dr. Rukmini already. And one of the few things that were sort of notable is that in this study, not all currently available medical options were tried. And although they said it is best medical treatment versus ST and DBS, that was not really the case. And here there was no sham surgery. It was just open label conversion to surgery. So some of the weaknesses of this early STIM study. And so of course the results were very good. And there is no sort of debate as to, we were all very happy that all these measures improved that Dr. Rukmini showed. And conclusions was that this was taken as evidence that early DBS improves quality of life in Parkinson's for a longer duration over medical treatment. However, this is not accurate, and we should be wary before drawing such conclusions. And actually, after this publication, there was a debate on DBS timing, and people started saying that why not improve the quality of life longer if we do DBS early. And it even led to US FDA approval 4 years after Parkinson's and 4 months after dyskinesia. This happened in 2015. Unfortunately, this led to some direct-to-consumer advertising, and people started advertising the industry. Why wait? And this was interpreted by some as a signal to do DBS soon after Parkinson's diagnosis, which was incorrect. Now, why do we need caution? So I will examine this issue based on in 3 heads. So caution is needed to interpret the results of early STIM and not just take it at face value. One is issues in clinical practice. The second is health economics, and the third is study design. So let us just quickly go over all this. So in clinical practice, of course, the positive part, we have seen that there's excellent, that whatever the timing of surgery, ST and DBS improves quality of life and motor complications. So that is all great. But the negatives, and there are many, so therefore that needs a separate slide. In fact, there are so many negatives. The negatives are inclusion of atypical Parkinsonism. So we will end up recruiting PSPP, we will end up recruiting MSAP, and this, this great story of DBS improving all the motor fluctuations, quality, that will all go down the drain if you select even one patient who has this. So therefore, this is a great danger in sort of selecting early. And this is an important point clinically, of course. The benefit to risk ratio is less when DBS is done early compared to when DBS is done a little later, as most patients have mild disease compared to the advanced disease a little bit later. So therefore, you are actually reducing the benefit to risk ratio if you're doing it a bit earlier. Now, motor complications, very important, do not necessarily get worse soon in the first few years. And we all know that these complications may stay mild for very long. And we have seen so many of our patients who don't need or who don't have all these motor, troublesome motor complications, because the rate of disease progression is variable and many patients have less rate of disease progression. And another point is Parkinson patients who develop gait and cognitive problems relatively earlier, they can worsen despite and sometimes even due to the DBS. We know that. So another few points are that younger patients with higher suicide risk. So these were also there in early STIM. And also if patients were operated earlier, they will live a greater number of years with implanted material and high re-surgeries. So these are some of the negatives. Now, the second point is on health economics. So already there are some studies showing the magnitude of QALYs after the DBS, and they show that DBS is cost effective by year 2. But very interestingly, this paper also shows by SPE in 2010 that doing surgery early narrows this economic benefit. Economic benefit is there, but it is narrowed if you do it relatively early. So that is an important point. Also, this well-known placebo and placebo effects, they were a big problem in the early STIM study. And we know that placebo effect is mediated by striatal dopamine release. And the magnitude of this is especially high in Parkinson's clinical trials because dopamine is directly involved. And so therefore, this was a big problem with the early STIM study. And also the strong positive expectation of benefit was there in patients who were given DBS in early STIM, and a placebo effect because of probably patient frustration. And so this is a well-known effect, which is a sort of a variant of placebo. This placebo effect was a problem in early STIM. So the people who were allocated to the medical treatment, they had a placebo effect. So another few points that the best medical treatment arm did worse compared to open label extensions of other medical treatment trials. And this was because, as I said earlier, only an algorithm was used in early STIM. Individualized tailoring of treatment was not allowed. And this is quite different from what happens in clinical practice. So therefore, this was not really the best way to study these patients. And another problem was, of course, the open label design of the study and using a subjective primary outcome measure, PDQ-39. So there were a lot of problems with the early STIM study. So then when should we really consider ST and DBS in Parkinson's disease? So as I said, on the face value, the study favors DBS soon after motor complications, but actually DBS should be best done before severe psychosocial and professional limitations arise. But it can be reasonable to do it when the benefit to risk ratio becomes favorable rather than considering it routinely at a given time. Now, in a given patient, the appropriate time for DBS is when the needs and expected benefits outweigh the risks. In a patient who has received all the objective and comprehensive information regarding individualized risks and benefits, and of course, a multidisciplinary team should thoroughly discuss if these benefits will outweigh the small risks. Of course, they should be at least moderately disabled. These patients should be in their ADLs in social professional competence by disabling OFS or dyskinesia. And despite adequate trials of medical treatment by movement disorder specialists or experienced neurologists, and as Dr. Lang has said famously, think not when to do DBS, but in whom to do DBS. There should be a lack of prominent levodopa unresponsive axial signs, speech, gait, falls, dementia, visual, all these should be absent. And there is remember, a high variability of rate of disease progression. So therefore, using a arbitrary fixed duration of motor complication should not be applied. And therefore, we should individualize. And DBS does not affect the rate of disease progression. Even Dr. Rukmini said that. So nursing home placement is not affected. Long-term survival may be affected, but really it does not affect the rate of disease progression. And Parkinson's is so heterogeneous. It has many phenotypes, it has many faces, it has so many genes, it has so many ages of onset. Every patient progresses at different rates. It has an unpredictable onset of fluctuations. When, in whom motor complications will become troublesome, we cannot predict. Now, axial symptoms, who will develop what to what extent, we can't predict. So therefore, jumping the gun and doing the surgery early, we will be in trouble because there will be many patients who will not be of a benign nature, who will have bad fluctuation, who will have bad axial symptoms, who may have a different disease. They may have PSPP, they may have MSAP. So nothing is to be gained by sort of jumping the gun uniformly and applying DBS in an early fashion, irrespective of what is going on in an individual patient. So actually, when the balance will tip in favor of DBS, this is a complex and highly individualized decision. This is best made by the treating movement disorder specialist or neurologist for that patient at that time. And one cannot apply a sort of a rule randomly. So one size does not fit all. And in Parkinson's disease, in whom to do, when to do, how to manage post-operatively, all these things are highly individualized, as we all know. And they are best tailor-made for each patient. So it's not only me, but there has been a lot of criticism in the literature by big voices regarding the use of early DBS in clinical practice in the last decade after this early stim came out. And I think that is all there in the literature, you can see. So just to conclude, these are my final 2 slides. Why late is better, and late meaning more than 3 years after the onset of motor fluctuations, not disabling type of late. I'm not asking people to take home the message that you should wait very late, let the patient become disabled. Then no, it is just that not to do it very soon after the onset of motor fluctuations. Wait for a few years, typically more than 3, 4, 5 years, and manage the medical fluctuations medically. And then when they become really disabling, you can't manage medically, then you do DBS. That is a traditional way. That is the best way for reasons I have shown. One more important point. Some groups have interpreted early as before motor fluctuations develop, and even suggest that early DBS means after 6 months to 2 years of Parkinson's diagnosis. This was also touched upon by Dr. Rukmini. And so this paper was by Charles in Parkinson's release, PRD 2014. And I think Dr. Rukmini had shown 2-3 slides about this paper. So this is actually quite wild, in my opinion, that immediately after Parkinson's diagnosis, patients are not even suffering from motor fluctuations. You are doing DBS before the onset of motor fluctuations. So, the patient does not have any basis, for any, they are not even disabled enough for you to do DBS. Now, Dr. Rukmini showed that 10 of these 30 patients in this paper, they were followed up for 10 years. And I would say that the patients, those did well after 10 years. They were lucky that they did not have MSAP, they did not have all the atypical syndromes, they did not have any gait or axial features. And, they may have been lucky, those 10 patients. It's a small study. But we cannot, apply this, generalize the results of this small, this small study. And because we have to be very careful in following these patients for a little longer, let motor fluctuations at least develop, let them become troublesome also after developing, and then do DBS. So we can't sort of over-interpret the results of that small paper of doing DBS even before onset of motor fluctuations. And actually, this sort of thing leads to a lot of misconception and misinterpretation of the term early DBS by the medical fraternity, because many start saying that early DBS means immediately after Parkinson diagnosis, which is so untrue. It is always after the onset of motor fluctuation. And these 4 points I've already made, so I won't repeat. I'll just say the last 2 things, that do not use a cookbook approach of doing early DBS in all patients diagnosed with Parkinson's, and doing late, meaning more than 3 years after the onset of motor fluctuations. That aids good neurological clinical judgment and aids our common sense of when a patient with Parkinson's is really going to benefit from DBS. Thanks.
Thank you, Dr. Pankaj, for favoring not doing DBS early. So before we get the second time have the poll, I'll just summarize the points by both of them. So Dr. Rukmini said that DBS is safe and effective. The medical management have limitations. DBS has been proven in advanced PD. Patients have done well more than 10-15 years on DBS. It leads to less levodopa dose. She also showed that even the non-motor symptoms also improve with DBS. Then she said that some patient with PD may develop early motor complications, and why prolong the agony to them, get them DBS, so social function will improve, quality of life will improve, it is safe in the long term. Why make them suffer? Why they have suffer in the agony? Then she even showed a trial where the patient underwent DBS even before motor complications started. That was a pilot project where she said that in that study, patients had better quality of life even when their DBS was done early. So she vouched that DBS should not be as a rescue but as a therapeutic tool. And why keep waiting and make the patient be in agony? On the counter to that, Dr. Pankaj said that for a lot of patients in the initial phases, medical technologies has optimum treatment. Why do you want to push the envelope? That is what he said. So he said that there were problems with early STEM study. It was an open label study. There were a lot of confounders. All the problems or limitations of open label study, he showed placebo, placebo. He said that a lot of this could be motivated by industry or commercial basis. He showed a lot of cautions while patients may have problems if we go for early DBS. Some patient may have atypical Parkinsonian. He talked about risk of benefit in the early phase. He said that PD is not one disease, it is heterogeneous and it can be various syndromes. He also talked about gait and cognition, which may worsen. And some patients may require due to surgery. He elicited a lot of confounders. And he said that not when to be done, but whom to select, what the guidelines are saying, that we should say. Regarding the thought of doing early DBS even before motor complications start, he said that was a wild thought. So I think that was the word he used. While Dr. Rukmini said that why prolong the agony and don't look it as a rescue therapy, but as a treatment tool. I think Dr. Rukmini wants to add a point. Maybe we can have them speak for a minute and then we can have a pause.
Yeah, no, I just want to confirm the statement actually that Dr. Pankaj also has made, that when we are talking about early DBS, we are talking about patients who have early motor fluctuations.
Yeah.
They are not before the onset of fluctuation. The reason why I showed the study, because the study was done, is to only show that the response, I mean the PDQ-39 improved, but actually it did not show a significant difference in the disease progression. So that was a study which you could have looked at the disease progression, but that didn't make a difference in the disease progression.
So for the early DBS, I think we all agree that we are not talking about PD patient diagnosed and going for DBS 6 months or 1 year into the illness. We all, I think all agree, all the panelists agree to that. So here we are debating doing it early when motor complication starts, or we still wait for a few years, try medical management, then go for DBS. I think we have listened to both the speakers. Let us have a poll again, and then we'll bring in the other panelists and experts, and let's see what they say. So before that, let us have a poll again. Can the team run the poll again?
Dr. Pankaj, you can switch off your slide share.
So you all can answer, the audience. This is the time for you all to pitch in. And now maybe you can start writing questions. Once the panelists say, we'll take up the questions too. Team, can you end it now?
Sir, shall I stop the poll now?
Yes.
Yeah, sure.
And let us see the results. Okay, I think so. A lot of people who were in the I am not sure, they have moved either way. So I think from that group, half of them went into with Dr. Rukmini, while a few more got added to Dr. Pankaj's point. Maybe we can now have if the speakers still want to pitch in something else more, Dr. Pankaj, Dr. Rukmini, they can say. By far, it looks 75% are for
poll actually, Soham, poll has significantly, it was half for not early DBS for Dr. Pankaj. Now it has become almost 3/4. So,
But even initially, early, it was 13% for Dr. Rukmini. That has also increased. Maybe
no,
initially
that was 30%, which has decreased now.
30. Okay.
Question was how many of the people actually voted in the first poll and how many voted in the second poll? Do you
Yeah,
have
because
numbers of that?
initially that is a sore point. Now
How
we have
many-
130
Who
people.
were there in the first poll? Numbers in the first poll and the second
That
poll?
were around 60, sir. So that have doubled.
Yeah.
The audience have
those
doubled.
people may not have voted in the first poll.
Yeah. So we will have it again once you, Dr. Charu, and Dr. Ravi share their thoughts.
No. We just want to know. Can you just give us those numbers?
It was around 60 in the beginning. Now it is 120.
So then they may not have voted in the first poll. So it's very difficult.
Yes, sir. So maybe you and Dr. Charu can again take this fight forward, and maybe Ravi also pitch in his thoughts, and then we'll run it again for the last time to reach a consensus.
I actually was making the few points when Rukmini was talking, and that's exactly what I wanted to tell, that when you do, when she was talking about the studies, they were the studies where the DBS was done when there was no motor fluctuation within 4 years of the onset of the disease. And these patients were on the medical treatment without fluctuations. So I'm again emphasizing the word without fluctuation. And when they followed up these patients, they realized that there was no difference between the onset of the dyskinesias or the long-term side effects of the DBS. So what they did observe was that the rest tremor improved. So these patients, the only thing that really made a difference was the rest tremor, and to some degree that they had a better quality of life while the DBS was working, and which was slightly better than the patients who were only on medical treatment. So definitely they did show that the patients have better quality of life, but they couldn't prevent the long-term outcome in the Parkinson's disease, and they couldn't make a difference to the onset of dyskinesias or development of dyskinesias in these particular patients. So that is the take-home message of going in early, what we are going to achieve and what we are going to
What
get.
does happen? Charu, I agree with you. But on the same time, what we do definitely see is there's a market control in the tremor.
Yeah, that is without question. That is without question. If the person has severe tremors and no fluctuations, we would still go for ST and DBS because the quality of life with the tremors is very embarrassing. Tremor is interfering with everything.
I agree. That is one situation where it can be considered, yes.
That's the only time where I would consider before the motor fluctuations develop.
And the second thing that has surprised me is neither of you have mentioned how does the Delphi criteria.
The question was whether early motor fluctuations is
mentioned that Delphi criteria that if you hit 5 tablets, patient's not happy, is still getting 2 hours of off or 1 hour of dyskinesia, that's when you should consider this.
Of course, you're talking about the patients with fluctuations, you should go for DBS. And you should go early in the fluctuations. We are talking.
I want to ask Dr. Rupam. So, sir, would you condone doing DBS in patients without motor fluctuations?
That's exactly what I'm trying to make a point. Without motor fluctuations, the only time I would consider doing the DBS if they have disabling tremors. Otherwise, I would not consider anyone for a DBS if there is no motor fluctuation. If they are
There's one more indication. The other indication is they are not able to tolerate levodopa very well. If they're not able to tolerate levodopa very well, their improvement is not very good. With the rest of the anti-Parkinsonian medications, you can consider it.
But then, do they have Parkinson's disease?
Yes, they have Parkinson's disease. You do on-off, they can tolerate it. You give them repeatedly, they end up with either hypertension or they end up with a lot of gastritis. They're not able to tolerate it. There are few patients, maybe 5%.
My opinion on this is like what there is a it is a gray zone. So individualized approach is the best approach, and this is okay done on a large group of 251 randomized patients and all. But when we look at our country, then there are several things which come into play, and while deciding on, we have to look at the family support system. and what kind of, within 3 years, obviously, the atypical Parkinsonism is the biggest fear which we have. And in early stem study, if you note, like it is pointed out, the tremor is fine. And even the rigidity will actually, over the years, will respond very well. But about the postural instability and, cognition, these are the two things which are, red flags for me. So individualized decision has to be made. And sometimes, if the earning member early, that he has a long life to, and sole bread earner and will well covered financially, then maybe I can try taking the early decision also. So that would depend on the circumstances in those situations. That is my take on this.
Dr. Ravi, I think I will not consider the DBS in patients with the postural instability. I think then you
No, that's exactly. So those are the things.
We're not talking about those patients at all. We are talking about the patients who are early without fluctuations and the patients with the fluctuations and still early into disease.
So madam, that is what I said. But when 9 to 11 years of duration, if you think, some of them will have a freezing of gait.
No. Early freezing of the gait is not the criteria. What we are talking about this debate is, will you go into the DBS when there is no fluctuation, when it's a clear-cut Parkinson's disease, good levodopa response? Will you go in for such a patient? Will you consider this patient for the DBS?
That has to be individual.
That is.
We cannot absolutely refute this findings, because very meticulously done, and if we follow the protocol which they have done, I think there is some.
Question. You are well controlled on Sindopa, 1 tablet 3 times a day.
And why do you need surgery?
Why would you need DBS?
That's why the Delphi criteria is clear. It's not only 3 tablets. You go up to 5 tablets. You are well controlled. Don't touch the patient. You have 2 hours of off, 1 hour of dyskinesia with 5 tablets.
That is after the onset of motor fluctuations.
That's exactly what.
Yes. Talking before the onset of.
Before the onset of the debate is on before the onset of
motor fluctuation. But Pankaj, it doesn't mean you wait for 3 to 4 years after the onset of motor fluctuation.
It has become
no doubt that we'll do it when there is motor fluctuation. The doubt is, will you do it before the motor fluctuation?
May I intervene? May I intervene, everyone, please? So I think the problem is happening is these words early and late. Yeah. And this has been a problem in the medical literature. What is early and what is late, right? So I think what we want, let us divide. So first is early, when we say, is it related to time from the onset of the disease, or we mean from the onset of dyskinesia? So I think there has been a paper which Dr. Rukmini said that even in patients with no motor complications, within 2 years, people have done DBS, and it has shown in that pilot study of 20 patients that patient who went on DBS, they do well. But we all agree that we don't agree with that paper, and we will not undergo DBS for such patients within 1 year of illness.
So that is why when I presented it, I did not present it for the efficacy of DBS at all.
Correct.
I only presented it as a pointer to ponder whether there is an impact on the disease.
Yes, but people have worked it, though, as Pankaj said, that is a wild thought.
Yeah, it is a wild thought. But
so we all, I think, at present in India, we all agree that I don't think we will go on to DBS within 6 months or 1 year of a patient who is doing very well on 1 or 2 tablets only.
Yeah, because that would mean doing Parkinson's. If you have Parkinson's, then do DBS. That would mean
no, that's not. No, that's not at all correct.
No,
that's why I say it is a wild thought.
May I interpret? I think let us probably there is too much of noise and no conclusion is coming out. I think let us hear the views from the individual rather than interpreting, and then
maybe that is a good point.
So thing is, sir, I am not a movement disorder expert. And I do see Parkinson patients and I do manage Parkinson patients. So, and as of now, what I understand that DBS is offered to the patient who developed a motor fluctuation, either the wearing of effect or levodopa-induced dyskinesia. So here are the 2 questions what Soham was again pointing, whether it has to be done early, that is before the start of the motor fluctuation. That will be the question number 1. And secondly, if it is as soon as the motor fluctuation starts, or you can manage with some drugs and after some time of motor fluctuation. So these are the two questions. So I think, Rupam sir, you can share your views on these two and what is your practice. And subsequently, we can check the opinion of other panelists also.
Right now, what we follow is the Delphi criteria. That is 5 tablets. You can go from 3 to 5 tablets of levodopa in one day. And if you get 2 hours of off and 1 hour of dyskinesia, that is the 5 to 1. Either one of the two you get. More than 5 tablets, do surgery. More than 2 hours of dyskinesia, off, you do surgery. More than 1 hour of dyskinesia, you do surgery. If it is anything less than that, 5 tablets or less, no surgery.
So, to coming to that, sir, you follow that criteria. I'm sure majority of you will be following that. But
Yes.
what do you think? Suppose a patient starts maybe having some motor fluctuation today. At what point of time, usually average patient will have fulfill the Delphi criteria? So usually that is the.
Normally, it takes 5 years, 4 to 5 years to reach that stage.
So that is the sir. Yeah. So the question is whether you do the surgery, offer the surgery immediately after the fluctuation starts, or you wait for 4 or 5 years when the Delphi criteria is fulfilled. That is the.
We don't do it when the fluctuations start immediately. We wait to make sure that we will increase the tablets to 5.
Sure.
If we still not control, but as you get on and off, we will then think of surgery and tell him that same. That these are the criteria. I have many patients who come to me early. I tell them we are not going to do surgery. We do not do surgery unless they reach 5 tablets and get 2 hours of off or 1 hour of dyskinesia. Anything less than that, we don't do.
Yes, sir. Also, your point is very valid. I think very stringent criteria when to do offer CBS. So maybe, Madam Dr. Charulata, do you follow the same practice, or probably what Dr. was saying?
What would you like to add? Amantadine, cefinamide,
No,
a longer
let's
preparation,
not go
and
there.
then
Let's
consider
not go there.
DBS?
No, let's not go there. Let's not go there. We are talking about definite criteria. We are not talking about adding safinamide, adding amantadine, or adding anything. Your best medical management is decided by you. Okay? Looking at the patient. Does the patient have motor fluctuations? Are the patient's motor fluctuations really not tolerable to him? Is the first question that you ask. If they're not tolerable to him, his off periods are bad, but his on periods are superb. Even with 5 tablets of dopamine, 3 tablets usually is very less dose. With 5 tablets and the best safinamide, the best amantadine, we know that the patients don't get control with amantadine and safinamides and all that. If they're going to have the fluctuation, they have it. These are the patients you do not delay in going for the DBS. You should immediately put this question in front of them that you have an option of curtailing your off periods and living a better quality of life. This is the ideal patient. So when they ask me who's your ideal patient for DBS, the patient who's on periods, during their on period, they're normal. That means they are like a normal individual. That means they have a superb effect of the levodopa. And during their off periods, they are not able to cope up with their day-to-day activities. They are not able to cope up with earning their daily livings. Okay. When we talk about freezing, we are a little late in the disease. We are talking about postural instability. We are a little late in the disease. That is a late. We have missed the bus and we are going a little later in the DBS. We will still get the benefit with the freezing. We'll still get the benefit with some degree with a lot of fluctuations and dyskinesias. But onset of dyskinesias also may be a little late for the Parkinson's going in for the DBS. It's the off period which is intolerable to the patient. That is the most important indication of the DBS. Of course, cognition should be normal. They should not have associated psychosis. Psychosis is again debated because they felt that the psychosis is sometimes drug induced, and we reduce the drugs after the DBS, and that makes a lot of difference. So when you mean early DBS, you should be very clear that early into fluctuations, not early into the disease, not
that is okay, man. So that's what we have been discussing. And Rupam sir is telling that usually, let us say, once the patient satisfies the Delphi criteria, okay, So you will also will wait till the patient satisfies Delphi criteria, or in some patient you may offer immediately after the motor fluctuation starts. So that is what the question.
Delphi criteria is 5 hours, 5 tablets, 2 hours off, and 1 hour dyskinesia. So if you're suppose he's getting off with 3
I
tablets.
wouldn't wait for the dyskinesias, Rupam.
No, I'm not looking for the dyskinesia. I'm telling you what the criteria
telling
is.
you the Delphi criteria. I mean, that's where Delphi criteria probably is going a little bit late than.
Okay, so you probably advocate a bit of early rather than
the off periods are miserable to the patient, unacceptable to the patients. You go in and do the DBS because it's the off period.
But that in the sense will mean early DBS, not a bit waiting. Right. You don't want to change the try for 1 or 2 years with medical management and see.
Of course, this is after the best medical management when the off periods are not tolerable.
No, ma'am, what Dr. Rupam says is that
no,
he doesn't want to talk about
I don't follow
Delphi.
I would not follow Delphi criteria. I think Delphi criteria is very loosely worded and loosely based with 5 tablets and off periods and dyskinesias. I think it's like one sleeve fits all. That's not.
But another my take on this would be that with the growing evidence in favor of personalized medicine, which Pankaj also brought out, we have to remember that several of these cases may have some genetic predisposition also, and that is another factor which is coming in when if you have any doubt on young onset PD who are having what will be the prognostication. There are several articles and literature coming up which shows that which are the groups of Parkinson's patient who will respond much better, who will not respond. So maybe that level of certainty can also be added up in the light of newer literature rather than clubbing everything together. So maybe that would another be a very interesting point.
Ravi,
Excellent point.
No. The point here is that only 10 to 20% of Parkinson's disease patients today have a single gene causing the disease. The vast majority, we don't know the disease. We think they are susceptibility genes and there are environmental toxins. We don't know the cause. So this vast majority, we cannot take this personalized medicine.
But sir, once the patient is sitting in front of us, we have to,
the vast majority of it, you do your whole exome sequencing, you are not going to get anything. Then what do? The vast majority of the patients are the patients who are coming to you, they're with medicines. And as Charu said repeatedly, it has to be with fluctuations. Without motor fluctuations, nobody is going to.
There is no doubt about those points. Dr. Charu has brought up.
No. The point is, when do you say that these fluctuations are bad enough? You can keep on increasing the drugs. People are on 10 drugs, 10 tablets. They're on 20 tablets. You don't want to reach there. But there has to be a finite number of tablets at which you stop and say, now you think of other things. You can keep on increasing each dose of the tablet. Each dose, you can make it from 5 to 6 to 7 to 8. And each one from 1 tablet to 1.5 to 2 tablets. You can add amantadine. You can add so many other drugs. When do you actually stop kicking the can down the road?
Unfortunately, sir, those who come to us several times who have money in their pockets and they are not the good candidates, and those who have all the criteria meeting up,
they may not have the
and
money.
they are not so it's in India, I don't know whether really we are able to match up these.
We are doing that now.
No, so
Dr. Pankaj wants to add
see, there will always be a patient-related factor and economy-related factor and a doctor-related factor. Those factors are there. Our point is whether, as a medical person, let us not discuss the cost and economy, but when should the DBS be done, early or late during the motor fluctuation? That is the whole issue. What I get from this debate and from the hearing from you all panelists, that once the patient, you give the best medical management and the patient still have very severe off periods or patient has significant motor fluctuation, it should not be delayed beyond that point. That's what I think I get the
consensus which you think, Dr. Chaturvedi.
This is what I think, so obviously.
Dr. Pankaj wants to add things.
I just want to ask Dr. Rupam and maybe Dr. Charu and Ravi also. So see, what is the role? Like, what is there any role or not of using our various tricks? And by tricks, I mean the things that we do to manage motor fluctuations. I mean, are you all saying that we should just forget about them? Like
I also was asking the same.
I didn't say that.
This is an important
we
question.
have spent our life trying to read, how to manage dyskinesia medically, how to manage. So at least let us try for 2-3 years.
So this is the thing. Early or late, we that 1 or 2 years where we can adjust by optimizing medicines.
Should
we
give that
doing
up
that, or we
just-
directly go for DBS?
Yeah,
This is
that's
the
what I want to
question.
ask you.
Yeah.
I used to do what I used to believe in what you do, but now I've stopped believing that because the outcome is so markedly different. In patients, they have to have fluctuations, but you don't need to push it down and down and down.
No,
There
but
are
not.
patients-
But at
I'll
least
just show you one video. I gave a patient advice in 2007. She came to me in 23 because she didn't want to get surgery done. There, she is psychotic. The brain is shrunk. It's one of the most shrunk brains. On the other hand, there's another patient. I do the surgery in 2007. She's happily cycling around now, 23, 16 years later. What are we achieving by doing all those tricks we learned? Have we not incorporated? See, this is new learning. All this time we've been doing DBS. I never thought that it will change dramatically this life. Now we are seeing these patients after 20 years. Is there a match, any match between the patients who've undergone a DBS 10 years down the line and those who have not undergone a DBS for 10 years? The quality of life is so markedly different. We don't need to push them down this road. We need to sort it out, have a definite timeline that this is where we say no. We need to do things better for them. And the whole thing has changed dramatically when you follow these patients for such a long time. We have been doing all these tricks. I used to put them on liquid levodopa, 10 tablets, put in 1 liter of levodopa, this thing in Sprite. All
It doesn't work.
That we don't like.
It doesn't work. It just doesn't work.
So what we need to decide is when is the exact timeline when we start saying that this is enough.
This is
and we need
enough.
to-
Yeah.
That's all we need to do. And as Charu said very clearly, fluctuations are a must, but it is not 2-3 years down the line.
So
Give
when
them
they say when they say best medical treatment, like what does that mean really?
It really means is that we've tried enough. You can't keep on trying anymore. Now we need to get them done and get them a better quality of life earlier. There's no need to push this down. This can doesn't work. I mean, kicking this 5 tablets, 7 tablets, 10 tablets. How many of our patients are on 10 times a day or 7 times a day? Are they better? They have a miserable quality of life. Do we really need to do this? You understand?
Dr. Rukmini also has raised hand.
But for a few years we can do it effectively, no?
There's not a few years. No.
No,
You do have a strong guideline that you get on-offs, and now you give them adequate number of tablets. 5 is the adequate number.
But there are so many patients where we give them these tablets and they really stabilize for 5 years, 10 years. They are
Keep
quite
them alone.
happy.
Don't
Once
touch
the
them.
fluctuation
Don't touch
starts,
them if they're not having offs.
Yeah. So
If
we
they're not,
are
don't touch
individualizing.
them.
So then we are individualizing, personalizing, correct?
Yeah.
I,
My
is that's the only thing, and they don't want surgical treatment. That's the only contraindication to this
Yes.
patient. You introduce the topic to them, you tell them that this exists, and then you let them decide what is their quality of life now and whether it's going to improve with DBS. Can they afford it? Can they go for it? These are the main questions that you have to put it in front of the
I agree
patient.
with you.
I agree that we should bring it up and leave it. And then, it takes a few years for them to anyway.
So I'll tell you that I used to see one young patient in my clinic. This was when Dr. Singhal had sent me this patient when I just started my practice. And he was very young and he had a lot of fluctuations. And so I said, you have an option of the DBS. And he said, rubbish, I don't want to do DBS at all. And I don't want to go for the surgical way. You manage me. And he used to manage his own Sindopa, travel from Virar to Bandra for his job. And then he kept going and we kept adjusting his doses over the next 5 years. And one day in the office, his off was so bad that he couldn't even reach the toilet. So he took a drinking water bottle and he peed into it. And the next day he came to me and said, I want to do the DBS. And he is given this story in one of the magazines. Either
But this is late DBS, no?
yeah, but he had told him 5 years ago and he didn't. And that is what I'm trying to tell you.
How many years back you told him?
When his off was so bad that he couldn't even walk to the toilet. So This is late.
5 years after.
5 years late. I introduced the topic. I told him you need the DBS. It was 5 years after that he came for the DBS.
You want me to show you one with 16 years later? When I told them in 2007, then they come to me in 23.
So anecdotes will always have.
Anecdotes,
maybe
yeah.
for lack of time. Maybe Dr. Chaturvedi is a non-biased person, not like epilepsy person. He is the one who maybe like share his final thoughts on what he could make out from what we all vouch. I think the main problem was what is interpretation of late and early is again very subjective, very individualized, I think. So that is the biggest problem here. Maybe Dr. Rukmini wanted to add something. I saw her hand.
No, that's correct. So that's why there is a lot of confusion on what is early, what is late. So when we started the debate was 3 years and more than 3 years of motor fluctuations. But actually there are problems with everything. Like say, suppose if you are using Delphi criteria, none of our patients who come in will be just on levodopa. They will be on trihexyphenidyl, they will be on pramipexole, they will be on cephalosporin, they will be on amantadine, and they will be on 3 doses of levodopa. That's it. So that's the usual. So you can't wait for them to go into 5 doses. So it all depends upon. So I think it's as Pankaj has very nicely said, and Dr. Ravi has said, it is individualized. So what we look at is if the patient is doing functionally, occupationally very well, don't do anything. Once they come to, they start having some, as madam has told, I mean, if they're starting to get some bad ops, increasing dyskinesias is something which tend to increase. So once you have dyskinesias, it's actually much more easier for us to tell them that the patient is going to require a DBS, because it will invariably increase, even if you try and control it. So, but with motor fluctuations on and off, then you have to tell them. And you have to tell them that it's just like another medication, so you can decide whether you want to get DBS or an extra medicine and keep on trying.
You have to introduce the topic to them. They will
Yes, that is a very valid point, madam. I completely agree with you that in anticipation of 1 or 2 years before or 1 year before, you have to tell them to prepare. Psychological, this thing introduction has to be very, very.
Sow the seed in their mind. Yeah. No, I agree fully.
We have another solution. We have a very busy OPD where we have both pre and post, and then we tell them talk to each other.
That may have bad repercussions too. I think Pankaj will agree. We had discussions.
They should know where they go. You have seen.
Maybe Dr. Chaturvedi can summarize and what he thinks in a non-biased way from what we discussed today. What is his final consensus thought? And should we run a poll at the end once we give a consensus? Do we want the audience to again vote?
Yeah, why not?
We can summarize and then the audience can vote, isn't it? So
yes, sir. So Dr. Chaturvedi, maybe you can be the best person.
No, I am not a.
No, because
what I have been doing and what probably have changed after this debate, that's what I can say. So till date, what I was doing is to obviously DBS to be considered once the motor fluctuation starts, either the wearing off effect or dyskinesia. And then I also used to do these all kind of tricks, doing adding amantadine and all these things. And probably I used to, at the same time, once this starts, I also introduce the topic of that, consider the DBS surgery. Obviously, many patients will not be very happy that. But now what I think that probably once, as soon as the motor fluctuation starts, and probably rather than waiting too long, at that point of time, what I at least consider now think that it should be offered rather than waiting for too late and doing all kind of tricks, because that is not going to improve over a period of time. So that will be my thought, but that is my personal what I thought it.
I'm happy. I'm happy that there's a paradigm shift, which is great, because even I realized 2-3 years back that we are doing it far too late, and that is what I felt. Number 2 is that we have to tell one message to all our Parkinson's patients: get your medical insurance. It's going to be a bomb.
Very aptly said.
Done when you're very early on. That is the other message I want to convey.
Very true.
All this is okay, but if you're struggling for money at that far end, it's not a great idea.
I completely agree, sir. Actually, the good insurance policy for elderly people are also lacking in a country. Probably that is another very important reason that even though they are capable of giving the premium also, no one has raised this issue at higher levels, and customized policies for senior citizens, in which include such advanced surgeries, should be actually there. And such an important component of society is being excluded because the insurance sector has never taken up this significantly.
These two, if you get these two messages across today, this would have been a very fruitful debate. Chaturbuj,
Yes.
I agree.
Yeah.
Yes,
So maybe the team can have more again, and then I'll take up a few
one
comments.
last point. I do hope that there will be a trial, randomized control trial, early versus late, and which will be following the patient up to 20 years, and then showing the benefit at
Like
some point of
MTS.
time.
You want me
Like
to show
MTS.
one video? I can show you.
No,
one
sir.
video.
That no video
No, sir,
will all
no,
we will
sir.
all will have videos and this, but in a
20
larger
years
group
later,
of
not
patients.
20 years later, 20 years later, after
Yes.
doing, that's what you're talking about. We're not talking about showing 5, 10 years. We have these patients. So we know what happens to them.
Can we run the poll? Team, please.
Sure, sir.
Can we have the?
Yes, sir. I'm just initiating it. Just 1 second, sir.
So do all agree that the current criteria are a bit restrictive, and we should a bit have them a bit early, or still you all feel that the second point is itself is there? I hope now we don't get. I am not sure. Maybe we
Request
can see
everyone
there is-
to please vote
Yes, please
for
vote.
the.
And then I can take up a few questions or comments.
Okay, we can show the results.
Not much.
Not much. Okay, so 65% say that not early. We need to satisfy the current criteria, and 1/4 of them still. Surprising is still 8% are still not still confused.
But the current criteria actually favor early DBS. That is a problem with this. With the
Which
current
Rukmini?
FDA has advised 4 years and 4 months.
That is early.
Yeah,
That is
fluctuation.
early. 4 months of motor fluctations and 4 years of
4 years, 4 months, no?
Yes, madam. So that is early.
The onset of 4 years? 4 years is okay, Rukmini.
No, ma'am. This is early motor fluctuations. So, ma'am, 4 years of disease with 4 months of motor fluctuations.
Yeah, that's fair enough. If the op periods are bad, then why not?
True, but what I'm saying is that the current criteria is actually early.
That's
not
exactly
late.
what
In
it,
terms
that's
of older-
exactly when you should do the DBS, not late.
Right.
I agree. So I'm just saying that the second group is also early only, not late.
Second group is early only. That's a early STEM study group, second group.
No. The point is that we, as movement disorder specialists who actually do DBS, have failed totally to convey the message what is early and late to the general population of neurologists. Forget about talking to the general people at large. That is what is the coming out of this entire debate. They don't know what is early. We are also confused. They are worse. Genuinely honest.
Same has gone on in the
That is
literature
what is
too,
the
sir.
whole issue. Chaturbuj. So that is where we are trying to move the paradigm, the goalposts, and make sure what we are telling them is clearer. You guys are very clear. 2 seizures, 2 drugs, 2 months. We have not got there yet.
Even there
But
is a
sir,
problem there too,
still
sir.
the waiting period for surgery is 20 years.
20
Average
years.
waiting
We are not
period.
talking about the waiting period. You are clear about your criteria. We are not yet that clear. We as movement disorder specialists need to get this clearer and very clear what we need to do.
Right.
You got the point. That is the paradigm shift we need. Amongst
That is the point. I think what means early at the after
Yes.
starting motor fluctuation, it is the duration, or it is the time period after the start of the motor fluctuation, or it is the severity of the symptoms, or it is the difficulty in controlling the symptoms with the drugs. So that needs to be better defined before we can really say this early or late.
Yes, that's why it was so much for the Delphi, because that makes it down to simple goalposts. 5, 2, and 1. And we know we are heading somewhere which can be easily translated and easily transmitted to the rest of the neurologists. That's why that.
So may I take the questions with the permission of all of you? So one question is like how much expertise is needed for advising DBS and sending to a particular center? Another controversial, not a controversial question, but yeah, a practical question. To a center that we refer, what sort of experience or expertise should we consider?
They should be doing 1 or 2 surgeries a month, but 1 surgery a month should be enough, because less than 1 surgery a month, your hands don't set. That's my strong feeling. If you want a good center, you want a reliable center, it can't be doing 1 off in a year or 2. You need to do 1 per month at the very least. What do you say?
Fair enough. Do you all agree?
Yeah, I also agree.
Because it's a very fine surgery. We need to be good at it. And if you don't do that much, I think you're just not at getting that reproducible results. Because there's a lot of expertise needed on the table for getting the electrodes in the right place and all that.
So there is a comment about MR guided focus ultrasounds versus DBS. I think Dr. Rukmini has already answered that. I'll not look into it. Just Lavin asks, most of the patients do prefer DBS later due to various reasons and all. Yeah. Should we start counseling early or late? Or when should we start counseling there? I think we still discuss. Maybe somebody may like to summarize it.
I think
what is the time when we start counseling?
So I think that there are 2 things. One is once the patient comes in as Parkinson's disease, just tell them that there is going to be a lot of medication and probably a lot of cost. So counsel them for insurance immediately as soon as you see them. Early PD, just make sure that they are getting it. The moment you start having motor fluctuations, I think we should talk about DBS.
And especially for the younger patients. So maybe for the younger patient, you should always give a heads up that take insurance and be ready. You might need the surgery. And when motor fluctuations arise, then maybe you can seriously.
Several people do not know only that. So once we initiate, then they start searching whether they have a coverage of CGHS, ESI, so many funding. So I think the 6 months, sometimes it just takes 1 year to get the paperwork done. So I think what Rukmini said is absolutely right.
Agree. I think just Lavin has said that. Dr. Charulata summarized it just perfectly. I think all of the panelists I think discussed very nicely. So they initially seemed to be disagree on a few points, but later on I think all agree that main issue is what we define early and what we define late in the medical literature is a bit ambiguous. I think for us all movement especially, I think first of all we need to end this ambiguity in what we mean by the term early, what we mean by the time late, and not looking into as years from onset of disease or is time from starting of fluctuation, but take it individually. And as Dr. Charu and Dr. Rupa Singh, if it starts affecting the quality of life fluctuation, this can start discussing and bring the point about DBS early, which should be the paradigm shift of this. This is the crux of the meeting today. I think I don't have any other points to add. Maybe Dr. Chaturbuj may like to end by saying something or anything else you would like to discuss.
No, I think it was a very well debated topic, and I really enjoyed it as a non-movement disorder specialist. Thank you, Dr. Rukmani and Dr. Pankaj, for the excellent debate. And I also thank you all the 3 panelists, Rupam sir, Ravi, and Charulata madam, for the excellent discussion. May I invite if Intas is providing logistic support for this. So if Mr. D'Souza is there, he can propose a vote of thanks.
Yes. Thank you very much, Dr. Chaturbuj. Good evening, doctors. I would like to begin by thanking the speaker, Dr. Rukmani madam, as well as Dr. Pankaj Agarwal, for participating in today's online debate titled DBS for Parkinson's disease, early intervention or last resort, wherein they both have strongly justified their respective stance of early versus late DBS in PD respectively. I would also like to thank as well the valued contribution of the expert panelists, Dr. Rupam sir, Dr. Charulata madam, Dr. Ravi Yadav, who being stalwarts in the field of Parkinson, have added their rich clinical experience to further augment the learnings of tonight's debate. My heartfelt thanks goes to Dr. Soham Desai, who as a moderator summed up the salient points of both the speakers of tonight. I also wish to thank Dr. Chatarbhuj Rathod, the brain behind organizing tonight's program, and so well summarizing the relevant points for the clinical practice. I wish to also thank the online participation of almost 453 doctors who are present for tonight's webinar and has helped making this program a good learning experience. A big thank you to all of you and looking forward to seeing you once again on every second Friday of every month, which would mean the next would be on 14th of July next month. Thank you very much and good night to all of you. Thank you.
Thank you, everyone. I think we had a good day.
Thank you.
Our next debate will be on headache, which will be moderated by Dr. Sanjay. So that will
So I
be the
request you all to just be on 14th July. It will be on New Delhi persistent headache. And Dr. Vimal Paliwal and Dr. Ravi Uniyal will be as a speaker. And expert panelists will be Dr. Ravi Shankar and Dr. Devashish Chaudhary. So I will request you all to be on that day also. New Delhi persistent headache.
Thank you, Dr. Sanjay.
Thank you, everyone. And we really enjoyed it. Thank you so much.
Thank you.
Thank you all. Thank you.